This is part 5 in my weaning and extubating series, and we are going to be talking about some weaning parameters and things that you might want to get before extubating a patient. At this point, your patient's been on a spontaneous breathing trial for at least 30 minutes, up to 2 hours. They are doing okay, tolerating it just fine, so we are going to assess for some weaning parameters. A little side note here, you will see a lot of different information out there about which extubating weaning parameters are the most important, which ones are not. You'll see different providers do different things. Some will always want an ABG, some will always want weaning parameters, some won't. So it really depends on the provider, the patient, the situation, the most recent evidence. This is just kind of all the stuff combined into one. So for weaning parameters, we look at RSBI. This is also known as your rapid shallow breathing index, and we want it to be less than 105. Then how you get this number is you take your respiratory rate and divide it by your tidal volume. We might also get a NIF, or negative inspiratory force. You may see this called a MIP, or maximal inspiratory pressure. We want this number to be really low, like the more negative, the better. And what this is essentially, there's a mode on the ventilator where you can put a hold on a patient's breath, and you encourage your patient to take a deep breath in, and this basically occludes their breath off. So imagine you taking a breath through a straw and me putting my hand against the end of the straw, and you're like sucking against a wall. We want to make sure that the patient has strong respiratory muscles and they're able to pull a big breath in even when they're having that occlusion, because that shows that they have more adequate respiratory muscle strength. Another weaning parameter we'll get is checking their minute ventilation, which we want this to be less than 10. So now we've got all the numbers. If they look good, I'll go to the provider and be like, hey, these are my numbers. Do you want an ABG? Some will say yes, some will say no. We also want to check for a cuff leak. A cuff leak is where you actually deflate the cuff on the end of the endotracheal tube and see if you can hear air movement around it. If you don't hear air movement, there could be some swelling in the airway. And then we're concerned about extubating patients and having their airway swell up and occlude off and put us in a dangerous situation post extubation. We also want to make sure that our patient is able to follow commands, they don't have too many secretions, they're hemodynamically stable, and that they are safe to extubate and protect their airway. So if your patient meets all of this criteria, or whatever criteria your provider has kind of customized for that patient, we will get an extubation order and go ahead and extubate the patient. And in the next video, I'm going to cover how we actually extubate a patient.